talking about the kind of, I guess, my impressions of what happened during the COVID-19 pandemic, which is still ongoing, by the way. But I'm just going to cover first of all, the virus pathway, because it underpins all of it, and I think sometimes we kind of forget what those key steps are. And then I'm going to go through kind of two vicious circles. Now there's more than two, but one I'm going to go through one on transmission and one on deprivation. And then there's going to be kind of a brief highlight of the brilliant science, and then it's going to go downhill again, talking about what actually happened and where maybe things should have happened but didn't. It doesn't have a particularly happy ending, this talk, so sorry about that. So I'll just start with the pathway and just go through the timeline of a coronavirus infection, because the timeline is quite different to, say, other terrible diseases, and that makes it much harder to control. So first you have exposure. That means there's someone in the vicinity of you who has COVID and is infectious and opens you up to the possibility of being infected. You might not get infected. Most of the time you won't. But say you are, then you'll become infectious probably about 2 to 5 days later. That time period is getting slightly shorter with the later variants, such as Omicron. And the key thing is you'll become infectious before you get symptoms. And that's what makes COVID so much harder to control than, say, SARS-CoV-1 in the 2000s, where you weren't infectious until you were quite ill. Most people develop symptoms. It's about 2/3. That might be coming down slightly now that a lot of people are getting reinfected. Or you may never get symptoms, in which case you can go out, you'll be mixing, you'll have no idea you're infectious, and people can get infected. That's typically about 2 to 7 days, the kind of first week. And then if you have symptoms, you might recover at home. That's obviously the most common thing that happens. Or if you get really sick, you might end up in hospital. And again, one of the features of COVID is that you tend to get really sick after about a week. It's not immediate. That's typically kind of days 5 to 14. And then there are 3 main outcomes, right? You recover from your acute infection. That's what happens to most people. Or you can end up with long COVID, so ongoing symptoms where you never quite recover fully, and it can take a long time to recover. Now that can happen whether you have symptoms or not. It's more likely to happen the more sick you are initially. So if you're in hospital, you're more likely to get long COVID than if you weren't, and if you have bad symptoms, you're more likely to get it than if you have no symptoms. And then, of course, there's the kind of ultimate bad outcome, which is death, which is rare, but when you have a disease that infects enough people, that can lead to very big numbers. And then what we realized after about probably towards the end of the first year of the pandemic is that really once you've recovered, if you haven't died, you can get infected again. In fact, a lot of people now are getting infected again. And it can be anything as short as several weeks. It's typically more like several months. But it does really depend on what variants are circulating when you guys got vaccinated and all the rest of it. So what are the impacts? So while you're infectious, so really for maybe 10 days, 11 days, there are 2 big impacts. If you're not isolating, if you're mixing, you can infect other people. And if you are isolating, then typically you might be off work or off education, which has a big impact on you. Especially if you have symptoms, you might not be able to work or learn. And if you're hospitalised, that's obviously bad for you, but it also then adds strain on the hospital system. And it also then exposes healthcare staff and other people who are more vulnerable, other patients, to infection. And actually, in-hospital transmission has been a really big issue this pandemic, and that recently it was estimated that about 30% of people in hospital with COVID got it in hospital. Death is the ultimate bad outcome, but long COVID is no joke for the individual. It can be really debilitating and life-changing. As a society level, it adds burden to the health system as people seek care for their symptoms that can go on for months and years, but it also takes people out of the workforce. And that can be really damaging, and we'll look at that a bit later on. And even once you recover from acute infection, there's now plenty of studies that show that your risk over the next year is elevated for death, diabetes, stroke, all kinds of issues that you don't want. I mean, obviously, those absolute risks are low, but they're higher than they would be if you haven't ever got COVID. So those are kind of the impacts. So let's now look at the the first vicious circle, which is for transmission. So I'm going to start with a high number of infections. And often now when we have waves, they start off in under-vaccinated groups who mix. So that's often children or young adults. And this is just the prevalence of coronavirus in England over time. This is the ONS infection survey. This is one of the things we should be really, really proud of in the UK. It's one of the few random surveys that have been going since the summer of 2020 that tests about 50 to 100,000 people every week. So it doesn't depend on people's testing behaviours, and it doesn't depend on the availability of tests. And you can see there in the summer of 2021, it was kind of Freedom Day when a lot of restrictions were dropped, and then progressively they've been dropped ever since. And by the autumn of 2021, most adults were double vaccinated. And it did not control prevalence. It has not stopped us having large waves of COVID. And in fact, various mathematical models have tried to estimate how does this prevalence chart feed into how many new infections there were. And basically there have been enough new infections since 2020 to have affected everybody in this country at least once, and somewhere between 1.3 and 2 times. I mean, that is a lot of infections going on. If you think the estimates that on average an adult gets infected with flu about once every 5 years, for COVID it's currently about once a year. And by age, the number of infections is highest in school-aged children. So if you have a lot of infections, then what happens? Well, a lot of people are off sick. In 2021, the Office of National Statistics said that COVID-19 accounted for nearly 1 in 4 of all occurrences of sickness absence in 2021. We don't have the 2022 data yet. And if you have a lot of people off sick for work, there's a lot of pressure on everyone else to go to work. There's more pressure to work when sick or infected, particularly if your symptoms are mild, or even if you don't have symptoms. And this has become worse now that the legal obligation to self-isolate positive was dropped in February. So effectively now there's this idea that before kind of employers were obliged to let you stay home if you had COVID, now they're not, and they aren't. And so we're seeing that people are being pressured to go to work if they have COVID, and cutting sick leave. So a lot of people, particularly in deprived communities, are forced to go to work. And that means there's more exposure and more infection. And that's not just for their co-workers, but any people they may be dealing with, particularly in public-facing roles. And that drives more infections, and every time you have an infection, there's more opportunity for mutation, and the more mutations you have, the more chance you'll get a variant that finds a better way of infecting people. And that's what we've seen, particularly since the age of vaccination. New variants have taken off less because they're more transmissible and more because they're more immune evasive, apart from Omicron, which was both. So if we go back to this kind of prevalence of COVID over time and map on the variants, you can see we had the original, then we had Alpha, which was a really terrible wave in January 2021, then Delta the second half of 2021, and then with Omicron it really kind of changed the game, and we've had 4 Omicron waves now in a year. BA5, which is the most recent variant, had a massive wave in July and a small wave in October this year. And now the most recent data is we're just starting to go up again, and we've now got BQ 1.1 and another one which is dominant in the UK, and then another one called CH.1. There's so many of these things now that's growing really fast and outcompeting it. Now, whether this will cause a big wave for Christmas, I doubt. Actually, I don't think it will, but it's not over. And if this doesn't, then the next one will. And then you go back into a new variant comes along and you have a new wave. So that's kind of one vicious circle. And the thing is, it matters, right? I think some people think it doesn't matter, this vicious circle. Once we've been vaccinated, it doesn't matter. But I'm going to show you, I hope that it does, and that lots of infections do have consequences. One of the first consequences is on education. So we've seen severe disruption in the 2021-2022 year from high levels of COVID. During the January Omicron peak, there were some days when 5% of all children and teachers were off sick with COVID. I mean, that's massive. There were weeks when 14% of primary school children had COVID. We saw this summer that the then Education Secretary said that long COVID was becoming an increasing problem in retaining teachers, and that it was eroding the workforce, which can have devastating consequences for the provision of education. We don't have enough teachers as it is. Talking about long COVID, the most recent data from the Office of National Statistics, this is self-reported symptoms lasting more than 4 weeks, is that well over 2 million people are reporting ongoing symptoms. That's 3% of the population. Now, about 650,000 of them say it doesn't affect them at all, which is good. But the rest say it does, and that includes 340,000 people who say limiting their daily activities a great deal. And this isn't something that has been solved by vaccination, right? That number has almost doubled since the summer of 2021. And if you actually look at ONS reports, how those numbers break down by the variant of someone's first infection, and you can see that although there's a big chunk pre-alpha, pre-vaccination, who are now got symptoms ongoing for 2 years, there's almost 750,000 people, over 750,000 people who've had long COVID from Omicron. Right? This isn't something we've solved. We've reduced its risk through vaccination, but we're infecting so many people that it's still causing really big numbers. Then there's the NHS and death impact. So I'm just going to start with death. So this is weekly COVID deaths in England and Wales. This is death certification. So this is if a doctor has said COVID is on the causal pathway of you dying, right? These aren't incidental deaths. So pre-vaccination, you have these two massive peaks, which I think we all remember. 143,000 people died in those waves. And then we got to really low levels of deaths in the spring of 2021. And then we opened up, right? We vaccinated, we're opening up. And although we've never reached these peaks again, thank God, and I don't think we ever will, this is still a significant burden of death. So since the summer of 2021, 50,000 people have died of COVID. Since January 2022 this year, it's over 30,000 people have died of COVID. And if we compare that to an average pre-pandemic year, there's about 27,500 deaths from flu and pneumonia, not just flu and pneumonia. So that's a significant number of deaths. And we've added that disease now to our population, but we haven't added any more resources to the NHS to deal with it. And effectively what we're doing is we're just making a slightly sicker population than we had before. If we look at it in terms of hospital admissions, again, you see the two really big waves at the beginning. And then if you look at it by vaccination, our vaccination has helped. There's absolutely no doubt that it has helped and reduced particularly pressure on ICU, but it hasn't stopped it, and it's been much less effective at stopping people in hospital with COVID than it has for deaths. And you can see we're still seeing significant peaks driving the hospital admissions there. And these next slides, I think, they genuinely make me really sad, because we went into the pandemic with an NHS that had been under-resourced for several years, that had much less capacity and resilience in it than some of our European peers. We already had a staffing crisis. We already had quite poor public health provision, and it responded, but I kind of feel like we broke it. So this is just a chart of average ambulance response times from January 2018 to September 2022 for serious calls. So there are loads of categories of ambulance calls. These are C2, so serious conditions such as stroke or chest pain, which might require urgent treatment. And the target is 18 minutes. You have to get there within 18 minutes. And it was a target that wasn't met before the pandemic. It's about 20 minutes, 20, 25 minutes. Now, since the summer of 2021, it's been consistently high, and it's now around an hour. And on any level, even the most serious, you're about to die calls, we're not meeting the target, we're nowhere near meeting the target. So, I mean, it's just really sad. So once an ambulance comes to you, and then it takes you to hospital, then the idea is you want a really quick handover of that patient to the hospital, right? The target, again, is 15 minutes, and the idea is it's better for the patient to get treated, but it also means that the ambulance team can then go and collect the next patient, they can see the next patient. And so every winter, so from November to March, the NHS collects what percentage of arrivals are taking longer than an hour to discharge. And these are years 2018, 2019 to 2020. This is before the pandemic. You can see there's an annual dip at Christmas, but it's about 4%, say at worst, 4 to 6% of arrivals are taking longer than an hour to discharge. The kind of first full winter of the pandemic, so 2020 to 2021, was a bit worse. You had that big alpha wave in January 2021, it pushed it up. But then actually, when you had lockdown for that whole winter, it reduced demand for ambulances. Then we look at last winter, 2021 to 2022. Things are significantly worse, right? Delta, you came into winter with a high burden from Delta. You then had Christmas, then Omicron hit, pushed it up. But Omicron was followed very quickly, Omicron BA1 in January, by Omicron BA2 in February, March. So by March 2022, it was back over at 12%, and it's never gone down. This year, we're right at the beginning of winter, and we're up at 15%. So we're starting off much worse than historical values, and it's a consequence of a year of NHS emergency crisis. If you go to A&E, the target is that you get seen within 4 hours from arrival to admission. And ideally, you would never take these 12 hours. Now, 10, 12 years ago, no one had to wait 12 hours. Towards the kind of like 2016 onwards, you could start seeing these little humps of winter where some people did. Since Freedom Day, it's just shot up, and now almost 9% of people are waiting more than 12 hours. 31% of people are waiting more than 4 hours. Right? These are the worst figures ever recorded for A&E. And it's not just me saying this, right? NHS leaders have been saying it. They've been, the president of the Royal College of Emergency Medicine, this is now over the summer, said the NHS has broken its promise to the public over the ambulance service. This basic social contract that you pay your taxes and we'll be there if you need us does not hold. And we don't see an end to it, right? We're just at the start of winter now. This is the bottom headline. It's from the BBC just last week, saying, patients are dying as ambulance face these crippling delays. Now that's emergency care. It's not really any better if you go away from that. Currently there are over 7 million people waiting for treatment in the NHS. That's 1 in 8 of the entire population. And that's record numbers. Now it was going up slowly before the pandemic. It's not like the pandemic caused it. That dip you see in 2020 is that first summer after COVID, and we basically didn't really have COVID. We had space to tackle that backlog, and we've lost that space. And now it's just going up. And that has consequences. People are dying while on the waiting list, and it's also having consequences for employment. And the other thing it's doing is more staff are off sick. So the red line is staff sickness in 2021, April 2021 to March 2022 compared to previous years, and you can see there's been significantly more NHS staff sickness than in previous years, even when those were the 2 years of the kind of the worst years of the pandemic. And it means that the NHS is becoming a really horrible and difficult place to work, and people aren't doing it anymore. NHS staff are leaving, and we have something like 10% of vacancies in NHS are unfilled. Paramedics are leaving. They're going on strike for the first time ever this year. Nurses are leaving, and they're now having their first strike ever because things are so bad. And GPs, let's not forget primary care, also having a massive crisis, pushed to breaking point. They're leaving, they can't recruit, and we had record numbers of appointments this last month, more appointments than we've ever had in GP practice, with fewer GPs, and we're still not, 1 in 7 patients are still not being able to get an appointment. Right? That's how bad things are, because we're a sicker population. So that was the NHS impact. And I think sometimes people don't get quite how bad things are. Economic disruption. Now, I talked about it a little bit, but just going back, and it kind of was most obvious in the first peak, which was one of the larger ones, the December COVID absences were the highest since records began. This is now a year ago. Flights were cancelled, plays were cancelled, hospitality was cancelled, public services really struggled with teaching and hospitals, social care, and so on. And so that's kind of the acute disruption when you have a wave. Like if 5% of your population is sick, it's going to matter, you'll notice. But also in long COVID, the highest rates of long COVID are in middle-aged adults, right, who are often in reasonably important senior positions in the workforce, 5% of that entire age group is reporting on COVID. The numbers of ONS stats from most recent stats on long-term sickness. Now, that's been going up, people with long-term sickness out of the labour market, but it's really accelerated just over the last 6 months. Part of that is long COVID, but part of it is the fact that they think now is the NHS strain over the last year is really starting to drive people out of the labour market because they can't get treated. So this is just, this summer you had business leaders at the Bank of England saying we have to deal with this, right? We're really affecting our economy with this kind of circle of transmission. So that is the kind of transmission circle. So now I'm just going to talk quickly about the deprived communities. The first thing I'm going to say is people are less likely to get tested if you live in a more deprived area. When they did the Liverpool mass testing pilot, that was when they piloted out lateral flow tests in the autumn of 2020, only 4% of people in the most deprived areas came forward for a range of reasons. But one of the big reasons is if there's a legal obligation to self-isolate on a positive test, and you cannot afford to self-isolate on a positive test, why would you get tested? If you do have COVID and you know you have COVID, you're less able to isolate. Often people are living in overcrowded housing or poor housing. They can't afford to. They have jobs where they can't work from home. We never had particularly generous self-isolation pay. It was always less than the minimum wage. And most people were refused who applied for it, didn't get it. That means if you're less able to isolate, there's more mixing going on, and the people around you in your community in more deprived areas are more exposed to COVID. It's overcrowded housing again, but also lack of green spaces, right, where you can safely mix. Particularly in summer, people who are living in more deprived areas just don't have access to those spaces. We also had a study that came out this year that basically was saying that people living in the most deprived regions have elevated risk of exposure to vehicle sharing, public transport, work or education settings, essential shops, non-household contacts across every survey period of winter wave in the pandemic, and that consistently elevated exposure is likely to contribute to differential infection risk in deprived groups. You're also more vulnerable to the impact of infection because you're less likely to be vaccinated. So that also means you're more likely to get infected and then more likely to be sick from it. This is data from July 2022, but it hasn't changed much. So you can see that people living in the most deprived areas are almost over twice as likely to be entirely unvaccinated compared to the least deprived, and only just over 60% have had a third dose of vaccine compared to 83% in the least deprived areas. And if you do get infected, you're less aware of symptoms. So there's been loads of studies, a lot of them actually done for SAGE, showing that people in the most deprived areas are less likely to be able to name the main symptoms of COVID, which were also incredibly badly communicated. These were the 3 symptoms that we were told meant you have COVID, and also meant you were eligible for a free PCR, which was a high temperature, a new continuous cough, or you've lost your sense of smell and taste. Now that's fine for the first year of the pandemic. By the summer of 2021, those were no longer the 3 main symptoms of COVID. The Zoe Symptom Tracker study said it was runny nose, headache, sneezing, sore throat, loss of smell. And that was confirmed by several other studies across the world. Like, these were the main symptoms of COVID. There was no communications campaign about this. If you had those symptoms, you were not eligible for a PCR test unless you had loss of sense of smell. And what makes me so angry about this is that in March 2022, lateral flow tests stopped being free, and within days they changed the symptom list, and they made it much broader and put all those symptoms on it. And I genuinely find that unconscionable, because we weren't telling people. It was all about take personal responsibility. Like, you're not even telling people what the symptoms are. Like that, you're not giving people the tools with which to be personally responsible. So, if you're less aware of symptoms, you're less likely to get tested, and the cycle continues. And this has consequences, right? This is deaths between March 2020 and December 2021, and adjusted for age, because people in more deprived communities tend to be younger. the death rates were over twice as high as in the least deprived areas. Also much more likely to suffer from long COVID, which also has impact because you're then less able to work, which exacerbates poverty. And those vicious circles interact. When you have high transmission, it disproportionately impacts on deprived areas, which then can drive transmission in particular regions, and so on. So now for some brilliant science, some kind of the good bit, if you like. Vaccines is the obvious one. Now we all know about 3 vaccines we've got here. We had AstraZeneca, Pfizer, and then Moderna. Now, everything's about the Pfizer and Moderna. But there are so many more. There are 172 vaccines in clinical development right now, and 199 that are in preclinical development. It hasn't stopped, and there will be better vaccines, and there will be longer-lasting vaccines. So that is pretty amazing. And in fact, to date, almost 13 billion COVID-19 vaccines have been given across 184 countries. And there we really do have just a vast body of evidence of how effective they are and how safe they are. And to go from a new disease in January 2020 to people receiving the vaccine in December 2020 is really quite remarkable. There's also been a lot of amazing science in identifying new treatments and developing new treatments. But there's also been really good science in identifying existing treatments that can work, particularly around steroids. That's the UK recovery trial, which they set up in 2020, which made it really easy to test things. And they tested and found that steroid worked, but they also really importantly said things like hydroxychloroquine and ivermectin do not work. And that's just as important to know. Mathematical modelling has had kind of a mixed rep in the pandemic, but I think actually it has had quite a successful pandemic. If you want to think, what are the scenarios I can try out, then there really isn't any other way to do it. If you're thinking about policy to affect transmission, you need mathematical modelling, and it has been really important for looking at how did we do our vaccine rollout, what are the priority groups, and I think it did extremely well in that. It looked at things like school opening and so on. I think where it fell down a bit was communication. I don't think it was ever that well communicated. It left a lot of space for people to misinterpret it, sometimes deliberately, sometimes not deliberately. We did a lot of really good work understanding who was at risk. We did that really quickly. Through the ONS infection survey, Imperial React study, national registries, audits, hospital records, GP records. We knew pretty quickly what are the risk factors in terms of comorbidity, age, and also, who you are and where you work. So we grew, ethnic minorities are at high risk, as were key workers. Surveillance has been absolutely crucial, and the UK is genuinely a world leader in this, and we can be really proud of what we did. The ONS surveys, the infection survey, is literally the envy of the world. We have such a good understanding of how infection spread in the UK. They also did things like monitor the economics, they monitored deaths, they monitored adherence to guidance and restrictions, like mask wearing, how people felt about it, all of that stuff. The UK Health Security Agency has actually been extremely transparent. Their dashboard is really good. All of it is API accessible and downloadable. They're still publishing things every week. They're amazing at doing the new tech reports on new variants. So they've also had a very good pandemic from surveillance reasons. And the COVID Genomics Consortium, COG, also a world leader. We're one of the countries in the world that does most sequencing and identifies very rapidly what the features of new variants are, and we should be really proud of that, and that's all public data that you can download. The other thing we've actually been really good at, which you hear a lot less about, is understanding transmission and how to prevent it. This is a paper from 2020, so within 5 months of it really hitting Europe, and it was recognised by them that aerosol transmission was an important route, so really bits of virus stuff and really small particles in the air that hang around for ages in rooms. And he was saying, okay, well, you can ventilate, like opening a window or mechanical ventilation. That's basically you're taking the air with the virus out and you're putting fresh air without the virus in. You can do portable air cleaning, so HEPA filtration, and what that does, it takes the infected aerosols out of the air. Or you can do what's called disinfection or sterilisation with UV light, which basically kills the virus inside the aerosols. And that's partly why it's really good to be outside, because sunlight kills the virus inside the aerosols. as well as you having fresh air. So there's been loads of studies that show that natural ventilation, which is like opening windows, can be really effective. It also showed that air exchange rates through mechanical ventilation, so if you have kind of air conditioning stuff in buildings, can be extremely effective. Studies showing that HEPA filtration is cost effective and really works. Even portable HEPA filters that you can buy, they're about that big, you plug them into the wall, can be pretty good. A recent study showed that, so the problem with UV light is that it damages your skin, so you need really high ceilings to use it, and that makes it less effective. But they showed that if you use far UVC, which is much less harmful to skin, you can still kill bacteria. In fact, they found that within 10 minutes it killed 98% of pathogen, and they said that could be a real game changer if that gets scaled up. We also found out a lot about masks. This is from June 2021, and this is comparing surgical masks to FFP2 masks, which are basically filter out aerosols, and they actually are masks that can protect the wearer. And they showed that if both people are wearing a well-fitting FFP2 mask, it massively reduces the infection risk compared to people wearing surgical masks. We've known that since the summer of 2021. In places like Germany and Austria, they made the FFP2 mask mandatory. In America, Biden mailed out FFP2 masks to every person in America. We've heard nothing about it here. Nothing. It's not a difficult message, but it was just never done. If you combine good ventilation and good masks, you can massively reduce infection risk. So this study looking at buses said that it can reduce infection risk by 91%. And we also understood what it wasn't. So when the pandemic started, it was all about surface cleaning. You know, wash your hands, hand sterilize, wipe everything down, have screens, and so on. But by the summer, we knew that really wasn't, that isn't really how it's spread, it is aerosol. So, you know, the US CDC, the European CDC are saying, you know, actually, it's respiratory, and contaminated surfaces is not, that's a really low risk. And in January 2021, there was a paper in Nature that said it doesn't spread through surfaces, why are we still deep cleaning? And what I find so infuriating is that we haven't moved on from that. You still go into shops, I mean maybe less so now, but where you get offered hand sanitizer, but nothing on ventilation, no open windows, no one's wearing a mask. I'm like, you know, have clean hands. Clean hands are a good thing, but they're not going to stop you getting COVID. And I feel like we haven't moved on from it. And I think part of it is because you feel like you've done something if you sanitize your hands that isn't actually very restricted, and then you don't have to worry about it. And I think because we can't see the air, we just don't think about it. But what I find quite interesting is this is all science, right? But it's physics and it's not medicine. And I think we hear a lot less about all of this science. We celebrate it a lot less. And I don't really know why. And I don't know whether it's because it's seen as a medical problem. It's a pandemic, it's a medical problem. And so physics solutions are just not prioritised. But I think it is something quite interesting to think about, like why we prioritise the kind of the vaccines over thinking about these kind of physics things for which there are solutions. So, potential interventions. You can reduce exposure. And what that means is you need to stop people with the infection mixing from other people. So you can ask infected people to stay home. So that's what contact tracing is based on. That's what they're trying to do. Or you can get everyone to stay home or just mix less or be less exposed. And that's things like lockdowns, limits on gatherings, working from home, social distancing, behaviour change. All of that is about trying to reduce the chance that someone with an infection is near you. You can reduce the impact of exposure. So if there's someone near you who has it, you can reduce the chance that they'll give it to you, and that's masks, it's being outside, it's cleaner indoor air. Right? Those are the three things you can do about it. Or you can reduce the impact of infection. So that's new treatments, it's access to treatment. So when you have a really big wave, and we saw this particularly in India in 2021, you need to have access to treatment, and if your health system is overloaded, you're not getting it. And arguably now in the UK, we're not getting access to treatment, not just about COVID, but anything. And you have vaccines, and vaccines impact all three of those things. That's why they're such a powerful solution. And so if we go back to this pathway, reducing exposure and reducing the chance of infection if exposed, reducing the impact of exposure, they're right here, right? They're a really efficient way to disrupt this pathway. if you only care about the impact of infection, you're really far downstream, and particularly if you're in a situation with exponential growth that's doubling every 4 days or a week, you're very quickly, that's not going to be enough anymore. And that's kind of where we were. Now, in an ideal world, vaccines would cover this whole thing, right? They reduce your chance of exposure because you're less likely to transmit. They reduce your chance of getting infected. They reduce your symptoms, they reduce your severity, and they reduce your chance of dying, right? They act across the board, that's why they're so good. And if we were still in a world that had the original variant, COVID would be over right now. But we're not. And they wane quite quickly from infection. So actually, the main impact of vaccines now is on reducing the impact of infection. And they're not acting upstream like we want them to. So what did we actually do? So in the first wave, in 2020, we reduced exposure, and the only way we did it really was lockdowns, and that's because we weren't testing. The UK decided not to test. We had no idea who had it, so we ended up just saying everybody just stay home, and that's all we can really do. And we had to reduce the impact of infection, and for that we reorganised the NHS. There were no treatments in March 2020. Then, from late 2020 to early 2022, we did all kinds of things. We tried to reduce exposure, and at various times it was the kind of combinations of lockdowns, limits on gathering, work from home, social distancing, behaviour change, self-isolation, contact tracing. Those are the things we tried to do. We tried to reduce the impacts of exposure. We did have mask mandates, never emphasised high quality masks, but we had them. We emphasised outdoor interaction. There was some communication around open windows, and we tried to reduce the impact of infection through treatments. Sometimes we had to reorganise the NHS. And we rolled out vaccines, and we rolled out vaccines very well. Now, since 2022, so since February this year, the only things we're doing is vaccination and treatments. That's all that's left. Now, as we've seen, vaccines don't really hit the upstream bit of the COVID pathway, and they're really vulnerable to new variants, but also new airborne diseases. And they have not stopped big disruptive waves. They have not stopped the vicious circle of transmission. So what else could we do? Well, we could reduce exposure by asking people to stay home if they're sick. I'm not necessarily talking about contact tracing. I'm talking about things like good sick pay. We have one of the worst sick pay rates in Europe. And countries that had 100% sick pay generally did better, actually, during the pandemic peaks. It could be things like changing the culture, so you don't go to work if you're sick, right? Don't give your co-workers flu, don't give them a cold, don't give them norovirus, right? We have this kind of presenteeism, and I feel like we've kind of gone back to it instead of thinking, maybe that's a really bad idea. Reducing the impacts of exposure is a biggie, right? Masks, outdoor interaction, clean indoor air, don't care what variant it is. They don't care what disease it is. If it's in the air, these things will work. And particularly when it comes to clean indoor air, it doesn't rely on anyone changing their behaviour. It's what makes it so powerful. It's one of the most sustainable things, and it's a public health good in and of itself. It improves concentration massively, improves health massively. So if we just look at this kind of combination, some of the things that went wrong is that we did contact tracing, and we're actually not that bad at finding out people who were contacts of people who had COVID. But we never routinely tested them, which makes no sense. We had a massive free testing program, and we weren't actually giving tests to people who were most likely to be infected, i.e. contacts of cases. As I said, we've had poor communication of symptoms. And again, we were really good at finding people who were contacts, and then really bad at helping them actually do the thing that we needed them to do, which was stay home. And since 2020, the SAGE behavioural subgroup and other SAGE subgroups have been consistently saying to the government, you have to support self-isolation or it won't work, and they never really did. On the deprivation, there has been no effort to plan to improve poor housing or workplace conditions or the health of people in deprived communities. We've known that's been a problem for 10, 15, 20 years, and we haven't created change. We knew from 2020, from the first wave, how disproportionate the impact was on ethnic minorities and deprived communities. and it didn't change, right? Nothing has changed. We haven't improved vaccination rates in more deprived communities. That has just stayed the same. And we haven't addressed exposure through environmental improvements at all. Other countries are doing it, we're not doing it. And what I think is quite interesting is none of these things, these aren't science things, these are all policy issues. And science can't do this for you. I think people want a scientific solution, but the solutions aren't necessarily science. Science can tell you what might work, but then someone actually has to put in the effort and do it. So, right, last slide. So there are many vicious circles in coronavirus transmission and impact. And the problem that we're trying to solve right now, or the solution we seem to have found, is let's go back to 2019. The problem is we're not in 2019. We have a new disease. And it's made us sicker, right? We can carry on with our lives, understanding that we're all going to get a bit more sick as we get COVID once, twice, 3 times, 4 times over the next few years. And the UK, and actually most of Europe, and states, seem stuck in like 2020 responses to a 2022 problem that's still about vaccination, whereas it should be about breaking the cycle of transmission, which vaccination isn't doing. And so the problem is, how do we interrupt that? And to do that, we have to really address the key drivers of exposure. It's a much more efficient way of doing it. It's more sustainable, and it has benefits far beyond coronavirus. In fact, the Royal Academy of Engineering, which we're sitting in, released a big report in June this year where they estimated that just improving ventilation, just improving fresh air, could save £174 billion over 60 years. If you could make buildings much more infection resilient through filtration and sterilisation and other kind of healthy building things, you could go up to 3 trillion in savings. I mean, it was massive. The next wave is on its way. We are just starting to go up. I actually don't think this one's going to be a really big one, but there will be another big one. But the next pandemic is on its way as well. There's currently a global bird flu pandemic, right? It's why we can't really get eggs. And if that jumps, then we're back at the really terrible flu pandemic that everyone was planning for before COVID came along to the party. There was an article that came out last week saying that they've identified a new coronavirus in bats, which they think could be just as bad as COVID if that jumps species. Climate change, migration, political stress, environmental stress is all going to make pandemics more frequent, not less frequent. Right? And it's the airborne ones that we have to worry about because they spread so much more easily. And so the sooner we start addressing some of these key drivers, the better. And what worries me about it is if we can't do this, if we can't think longer term, if we can't think about improving the resilience of our societies, if we can't work internationally and learn from other countries and implement policies in concert with other countries to mitigate pandemics, then how can we tackle climate change? And fundamentally, climate change is a much bigger and more difficult issue. So, that's it.
Really, really interesting. Now we've got time for questions. So, any questions? Got one there. Gavin's on the roving microphone. Actually, there's a group of 3 just there, Gavin, where you're standing. So,
thank you. You distinguish between science issues and policy issues, and I'm going to concentrate on the policy issues and the modelling. Our perspective, possibly as modelers or people who have a relationship to modelling. I want to ask 2 related questions. One is looking backwards, and one is maybe looking forwards. There was a scenario testing process that went on and put a pandemic at the top of the risk register for the United Kingdom. I can't remember what it was called. Was it Operation Cygnus or something like that? And they tested a different virus. But actually it revealed that we needed lots of PPE, which we didn't have. Had they actually done anything without being at the top of the risk register, we would have had much more PPE, and no doubt Baroness Mohn would be less rich than she is. So it's a failure of the relationship between analysis and political decision making. Same thing seemed to happen during the actual pandemic, which was that I'm trying to work out how to say it. Take the example, the Royal Society put out a request for modelling assistance from our community, and the one thing they weren't interested in was how the modelling would interact with the political process. In operational research, we have a lot of experience of that. That modelling that's done separate from decision makers is not really anything like as good as one in which they come together. And I wonder what your view were on these two failings and whether we could do better.
Yeah, so on the second point, I think what is really interesting is that the way SPI-M worked is that they were given scenarios to model. They were said, right, these are the interventions you can model and you can't model anything else. And so they never really had any freedom to say, well, actually, if you did this, you'd have a much bigger impact. And they weren't really allowed to talk to other experts that would help them make bigger models. And one of the biggest examples of that is care homes in March 2020, when they didn't know how care homes were staffed, and they didn't know that there were a lot of agency staff who worked across different care homes. They just didn't know it. And they also didn't know that they weren't entitled to sick pay, and so couldn't really afford to isolate. And they also didn't know that because we relied a lot on migrant labour for care homes, people tended to live together and were overexposed at home to getting it. So none of those things were known. Now, I'm not saying that a mathematician should have known that, but there should have been a way, someone knew it, right? It is known, it's a known thing. Why was it so siloed off, right? And I think that's something that we haven't really learned, and we haven't really allowed for more things. Now, on the first question of Cygnus, I think the issue is, I don't think politicians should be involved in long-term policy, whether it's climate change. But I'll tell you why, because on a 4-year election cycle, no one's ever going to vote for you because you say, I've got loads of PPE for the next pandemic, right? Unless the pandemic's here, no one cares. And it's never going to be your priority. We're incredibly bad at planning 10 years, 20 years, 30 years down the future. And so somehow that has to be made independent and given support, cross-party support, and people can just go ahead and do it and do the things that benefit. Because I think actually, Keir Starmer said it the other day. I'm not always his biggest fan, but he said, you know, we're always doing sticking past the politics. And whenever anyone tries to plan for the long term, they get criticised as a politician of that's going to take ages. And people always want the quick fix, and that means you're never going to get the efficient fix. And that, I think, is a problem. And until you change those timescales of where your incentives lie, I just don't think nothing's going to change.
Many thanks, Christina. Just a good story initially. I remember turning on the TV and saying to my wife, that's Christina from UCL. And I thought, how fantastic. I mean, I really admire you for standing up to be counted, so thank you for doing it. Just a couple of questions, really, about response, I guess. The Chinese response has been very much in the news in the last 10 days or so. I wonder if you'd like to comment on that, really. And also, and linked to that, I guess, is this just a problem with democratic politics in one sense? I despair when I hear younger people sometimes, as now sometimes now registered on Git, that what we need is a benevolent dictatorship. And my response is, they don't exist. They don't exist. So what would your comment be on the Chinese experience? And do you think any other nations did a much better job than we did?
So on China, it's been quite frustrating because you've seen people like writing in newspapers or on news saying China's had draconian restrictions for 3 years, blah blah. And I'm like, they haven't. You know, I think up until this summer, the average person in China would spend about 5 days or less in lockdown. When there was an outbreak, they had very severe restrictions for a short period of time. But because they closed their borders, which is its own restriction, but within that, life carried on as normal, pretty much for most people. Now, where China went wrong is that they just haven't vaccinated enough, and they haven't used the best vaccines. So I think only about 60% of over 80s have 2 doses of vaccine, and they are mostly vaccinated with the Sinovac, I think, which is much less effective against Omicron. it was pretty good actually against the original variant, but not against Omicron. And they're very, very reluctant to use what they call the US vaccines. And they also have not brought in the treatments like Paxlovid. And we saw in Hong Kong, when Hong Kong had an Omicron wave in February, devastating deaths, like on the level that we had in our worst wave. So if China lets it go now, I think someone did a mathematical model of it, was published a couple of weeks ago, they think like over 1 million people will die. And that's still less than the death rate, say, in the States, but it's a lot of people. And they haven't really got any other mitigations in place. They've got contact tracing, but they also haven't really done anything on ventilation or transmission. I think they kind of became a bit too complacent, and now it's out of control, so I don't think that's going anywhere good, unfortunately. In terms of kind of your other question, you've had countries that had a high level of trust in their government and in each other did better. So that includes the Scandinavian countries, it includes countries like Japan and South Korea, but also countries like New Zealand, where they actually had really good communication and quite consistent communication, also did pretty well. So New Zealand and Australia now had big waves when they opened up, but much fewer deaths and much less hospitalisation. They benefited from delaying infection. There's still benefit to delaying infection because we are still getting better treatments and better vaccines. It's still, a year from now, there'll be a better booster. So it's always better for you to wait, but harder to do nowadays. So I think there are some countries that have done better. And interestingly, a lot of middle-income countries did pretty well, like Vietnam, for instance, some places in South America, Uruguay, had some really good moments, and that's partly because they still have a really strong public health infrastructure. They have a network of public health workers who are used to going house to house for vaccine delivery, nutrition advice, early newborn care, that we used to have, but we stopped over the last 40 years as we basically vaccinated our way out of infectious diseases and improved hygiene and quality of living. But we used to have that infrastructure, and now we don't have it. And actually, that means that we were much harder for us to do things like contact tracing, and also we're much less scared of infectious diseases than perhaps we should be.
In the brief for your talk, Christina, it suggested that you were going to call for a systems approach. You didn't actually do it. Even though all your slides and your talk tended to suggest that that was exactly what was necessary. The real point being, I guess, is that people on SAGE, and indeed on independent SAGE, are from quite narrow disciplinary backgrounds, and that may indeed prevent them getting to a systems approach which appears to be absolutely necessary for what it is that you've been saying.
Yeah, I didn't call for it because I kind of thought it was implicit in the whole. I think, yes, that's obviously what you need. I will say, being on independent SAGE, that I think people have come to appreciate the other disciplines a lot more. And I've learnt loads, particularly from the behavioural scientists, but also from virologists. For someone who hasn't done biology since they were 15, it's quite eye-opening. But I think it's interesting because the government obviously has really good OR, but it didn't really seem to get much of a look at. It seems to be much more about how do you deliver a specific thing, like this is what we want to do, now we'll get the old people to do it. But not actually the much bigger picture of where is it most efficient to intervene. Didn't seem to be there.
There's another question over here, Gavin. Oh, then over there.
I think the scariest picture that you showed that really worried me was what was happening to the NHS and the lack of capacity in the NHS to deal with really incredibly pressing problems now in terms of numbers being sort of treated and response times. Do you have any sort of ideas as to what can be done, apart from just trying to throw a lot of money at it? Are there any sort of more cost-effective ways of handling that situation?
So what makes me really sad about it is that I don't think there are any easy solutions. And you've seen this a lot, right? When organisations are in crisis and you have this kind of level of understaffing and stress, they can become more toxic. And we've seen that in the NHS for a while. Like if you look at the annual survey, it's about 25% of people report bullying. You know, like it's an incredibly difficult place to work. You have the cost of living crisis, so nurses and other NHS staff need to use food banks, and it's just I just can't see how it's recoverable. And I wish I could. Yes, investment. Yes, we need more trainees. Yes, we need more migration. We also need better buildings. We haven't invested in the NHS estate for 12 years. I think the King's Fund estimated that's costing £3 billion a year alone, just trying to stop the roofs falling down. And we're kind of in a situation where most people don't need hospital, and many people don't see them. They don't know people who do. But if you do, I think you have seen it. And you know, it's a kind of situation where just don't get sick, and that's quite scary, right? Don't get sick, don't get an accident. And you know, I've been talking to a lot of people who are quite senior in NHS England, and they can't speak out. And there's been this other issue that the NHS doesn't want to stop people seeking care if they need it, and so they can't say we're struggling to treat you, but at the same time they are. And so they come to me and they say, it's broken, we've broken it. And it's just, so that's why I'm saying it. I'm saying it because they're saying it and they're asking me to say it. And it's just very sad. And until we can stop people leaving, I don't know how we're going to solve it. And then you have these really crazy things like the pensions thing, where senior doctors are disincentivised from working to clear the backlog because it'll cost them tens of thousands of pounds. I mean, that's just crazy. Like, what the hell are we doing? I mean, it's just nuts.
Gavin, we've got a hand up here, and then there's one at the back after that.
Thank you, Christina. David Lane. Thank you for coming into my living room during the pandemic and being a voice of reason on Channel 4.
Makes you sound a bit scary.
No, it was fantastic. Thanks for a talk that made me want to get a stiff drink. Maybe you need one too. There is a question here somewhere. To respond to Mike, yeah, I think you've nicely diagnosed actually the systemic nature of it. I think there's a version of our future in which the UK is headed for systemic collapse, and we end up being a failed state. The solution is simple, of course. We need to switch to using imperial measure. That will do everything. Now, but looking back, not knowing what we know now, which is unfair, but knowing what we knew at the time, if things had been done differently, how many lives could have been saved?
So I think the first wave, probably, I think there were estimates 20,000 just by locking down a week earlier because of that 4-day doubling. I think there was it was so new, and just looking back on that, there was so little we knew that in some ways I don't blame some of the mistakes we did back then. But the second wave did not have to happen. By the summer of 2020, we knew about airborne transmission. We knew about the danger of indoor environments. We knew that contact tracing could work because the Asian countries had demonstrated it worked, right? Because initially it was like, oh, there's no point, we can't possibly test, it'll never work. They showed it worked. Japan never locked down and have had far, far fewer deaths and severe illness than we have. And we just refused to do it. We basically were like, we know better, and we didn't. And we did these kind of weird things like curfews. I'm like, seriously? Like an hour earlier? And what difference is that ever going to make? So that I think I find quite upsetting. And the fact that we knew about the impact on inequality, but we just haven't done anything. We just keep writing reports. Like the one thing we're so good at is documenting it all, but actually doing something about it seems a bit beyond us for whatever reason.
Thank you, Christina. Thank you for an excellent presentation, frank and honest, and painful at times, to be honest. I'm part of that government interface of OR and the politicians, and to pick up on some of the comments earlier, Jonathan's and some others. It's sometimes bloody hard to get people to listen. There were OR people involved actually in SAGE and SLIM, and there were OR people working on lots of other aspects of the pandemic as well, and on the contingency arrangements. What I'd be interested in is, obviously on independent SAGE and SAGE, Patrick Vallance is a systems thinker. He knows an awful lot about those processes, but they weren't being used. I just wondered how you felt that independent SAGE was doing things that SAGE wasn't, or would have done things differently. Because I can remember sort of going in, like you were in my front room as well, and I was quoting things that you were saying back in the office. Sometimes I was listened to, but not always. But I'm just interested in how they might have operated differently, as opposed to being two separate organisations.
I mean, I think if I could have my time again, I would never call this independent stage, because that isn't really what we were. I mean, not least because stage is, 200 people? And we were 12 people doing it in our spare time. I mean, it's not comparable. I think some of the big difference is that we actually always did work together, and it was quite broad expertise, although not that many people. We had a lot of public health, particularly at the beginning. We had Martin McKee, who's now president of the BMA, but an incredible public health guy. Like, he's so good and has worked in really intractable public health issues for decades. And Gabriel Scally, who's unfortunately has been unwell for the last year, so hasn't been able to partake, but he used to run public health in the Southwest and stuff. So we had that expertise, which was really valuable, and there wasn't that much public health expertise on SAGE. But I think what we ended up doing quite quickly is switch over to communication and talk about what was happening, talk about the evidence, try and explain the evidence, try and explain why the measures might work, why they might not work, and what might happen if they didn't. And I think we spent a lot more time on that than say, well, it wasn't SAGE's remit to communicate, it was their remit to give advice to the government, and then the government communicated. But I think it was never that clear. There was a lot of information out there, all the SAGE minutes, which have so much in them. The SAGE minutes are actually brilliant. So many amazing reports that never really saw the light of day because they're in a 50-page PDF hidden on a government website. And that, I think, is quite sad. And we tried to do that, and we still try to do that now.
There's some hands at the back there, Gavin.
I thought everyone would be bored of talking about COVID.
Thank you so much for the talk. I wanted to hear your views on the public using technology to tackle this pandemic, particularly contact tracing, like you mentioned. What did the UK do? Was it effective? If not, why? And what did countries in Asia do that was effective? And in your view, what is the most effective way for contact tracing to work?
So, the first thing we did is we wasted 2 months building a bloody app. It didn't work to begin with. As if you just had to find the people, right? And we kind of somehow assumed that once you found them, everything else would take care of itself. But none of it works if people aren't isolating. And so there are 2 ways to get people to isolate. You can either make it really easy for them to isolate by paying them and providing food and taking over care and responsibilities and so on. So for instance, in New York, you had the choice to go into a hotel and someone would go and walk your dog or look after your elderly relative, all of that stuff. Or you can force people to isolate by locking them up, or by using technology, and having, so like in South Korea, you would have apps that would show if you left your home, and then you'd get a call, which is quite invasive, but it worked. So I think what we didn't do is pay enough attention to that bit of it, the actual bit that makes a difference, which is stopping people leaving. And I think we never really explained to people why it was important, because all of the other restrictions about curfews, lockdowns, working from home and so on is predicated on the idea that you don't know who's infected, so everybody has to restrict their behaviour. If you can concentrate on only restricting the behaviour on people who are likely to be infected, everyone else can live their life as normal, and the idea is that you can control it pretty well. And many countries did. Now, Omicron did change things, but that's what I think we didn't really do. I mean, 500 quid for 2 weeks, that's not enough. I just never understood why people thought that would be enough. I don't understand how it's legal without it being the minimum wage. And most people didn't even get it. I mean, it was just, I don't know, crazy.
Thank you for a really good talk, Christine. I really enjoyed it, and for all your tweets over the past 2 years, which have hit my Twitter. Been a lot, yeah, they've been great. A lot of the suggestions you've had of things we can do to improve are kind of rather boring sounding things that we need to do. Whereas developing a vaccine or something like that is really exciting and new and fancy science, which people don't quite understand. Whereas I think they understand the public health stuff, which maybe makes it sound a bit dull. Is there a way of making the public health measures sound more exciting so that people do actually do something with them?
I mean, you're right. Like, people like, well, they like magic bullets, and if the magic bullet says AI on it, or magic DNA, then they'll like it even more. I think the biggest problem with the public health measures isn't just that they're boring, it's that they're hard. And no one likes difficult solutions. And no one likes things that take a degree of upfront investment, like improving ventilation infrastructure, for instance. I think one of the issues I find with OR is, in general, is that actually often the best solution or the most effective solution isn't the most exciting solution. And people don't really like working on it, and also clients don't really feel like they want something flashy for their money. And that's just the constant challenge of OR, right? So you have to, I guess you have to make the outcome exciting, which is a better outcome, right? But how to do that? I mean, I'm not
AI-based OR.
But why AI? I mean, like, machine learning isn't going to solve these problems, is it? Ever? I mean, this just isn't. I mean, it's great, go for it, but anyway.
Okay, thank you very much. I'll have to call a halt there. There were still some hands raised, Christina, which I think is testament what a fantastic talk it was and how interesting it was. But I'll have to